Yes, thank you for giving me the opportunity to kind of summarize my talk. It was really focused on options, beyond that secondary relapse onwards, when patients have already had a reasonable exposure to proteasome inhibitors, first-line proteasome inhibitor, bortezomib, as well as immunomodulatory drugs like thalidomide and lenalidomide, and some may even have had exposure to a monoclonal antibody. And what I try to do in my talk is cover the most recent data with the triplets, including the combinations of daratumumab with pomalidomide dexamethasone, the combination of daratumumab with carfilzomib dexamethasone from the CANDOR trial. And I also covered the ICARIA data with isatuximab, pomalidomide dexamethasone. I also discussed the potential role of venetoclax in translocation 11-14 patients, as we had the BELLINI clinical trial data, even though these are not approved options, but at least in the US market, we are able to get venetoclax for a subset of myeloma patients. And I discussed the different BCMA strategies that were presented at ASH, including the bispecific monoclonal antibody from Celgene, showing good activity in earlier cohorts of their dose escalation phase 1. I also discussed updates from the BB2121, BB2121-7, as well as the J&J 4528 CAR T cell clinical trials, and showing the nuances between each of those different protocols and responses in patient populations. So that, in a gist, was the summary of the updates I provided. I broke down the potential options for each of the patients based on prior treatment exposure and drugs given. So it ends up being a very individualized kind of a decision for each patient. The physicians have to look at the whole picture, prior therapy, side effects, before picking the treatment options. We always prefer enrolling patients on clinical trials in that setting, and I want to emphasize that point. Most of the experience we have is in a phase 1B study that treated a little over 100 patients. I believe Ajay Chari had published that paper about a couple of years ago, where the response rate was about 60% in a relapse refractory myeloma patient, with a lot of patients actually being len refractory in that experience. Then the ICARIA trial that compared isatuximab PomDex with pomalidomide dexamethasone in relapse refractory myeloma patients included patients who were len refractory. And this trial read out positive in favor of the three-drug combination, where the median PFS, which was the primary endpoint, was a little over 11 months for isatuximab pomalidomide dexamethasone, and it was less than half of that for the standard of care arm. So the study was positive, and it's the only phase 3 trial we have at the moment, with a monoclonal antibody being combined with pomalidomide dexamethasone. I also discussed the ELO-PomDex data. So these were the Eloquent 3 trial data, which was a randomized phase 2 trial, not a phase 3, comparing ELO-PomDex to PomDex, showing very similar outcome results, median PFS of about 11 months or so, and for PomDex, the median PFS was less than half of that. Depth of response was also better with ELO-PomDex. And then, I talked about the combination of DARA-KD with the CANDOR trial data that were presented at ASH as a late-breaking abstract, showing that the three-drug combination with DARA, carfilzomib, dexamethasone being superior in terms of median PFS, overall response rate, VGPR and CR rates, as well as MRD negative CR rates at 12 months. The median PFS was not reached with DARA-KD, whereas it was close to 16 months with KD. And these are patients who, I think a third of the patients on the DARA in the CANDOR trial were exposed and refractory to lenalidomide. So these clinical trials are important combinations that are to be considered for patients in their second relapse and beyond. With the BCMA bispecific monoclonal antibodies, we're seeing a response rate in a small subset of patients getting 50% or higher, which is quite encouraging. The BCMA CAR-Ts are showing response rates of over 80%. If you look across the different studies, the J&J 4528 study that had reported 29 patients showed an overall response rate of 100%. The KarMMa-2 data, or rather the KarMMa-1 data, was showing an overall response rate of over 70%. What we're seeing with BB21217 is a response rate, of about 80% or so. The CRS rates and neurotoxicity rates were within these bispecifics and the CAR-T trials are a little different. Bispecifics appear to be a little better, much better tolerated than CAR-Ts, and are an off-the-shelf option for patients. Amongst CAR-Ts, the Janssen product appears to have lower rates of grade 3 or higher CRS and neurotoxicity rates compared to the BB121 products. At the end of the day, I think the safety profile will probably be the distinguishing features between these different CAR-T products.